So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z.
What's good, fam? It's your host, Jimmy Pruitt, aka PharmD and the ED, and I'm bringing you the episode of the Pharm So Hard Podcast. I'm super excited today to talk about the use of epinephrine for anaphylaxis. But I'm sad to tell you, I think you have been doing it wrong. You've been using epi wrong for anaphylaxis. And we're going to go into exactly why, how, and realistically, what can we do to fix it? But before we get started, I want to go ahead and set the scene. I want you to really get a sense of what the call is like when EMS calls us to get us set for the mindset. And I'm going to see if you can capture what was done wrong here.
Unit 7 to main ED. We have a 37-year-old allergic reaction to shellfish. 0.3 IMFI given to the left delt. How do you copy?
How do you copy? Again, that's a 37-year-old that came in with anaphylaxis to shellfish. They gave epi to the left delt. They gave 0.3 milligrams at that. Is it the right dose? Is it the right route? Is it the right thing altogether? Or did we just mess all this up? And we've all been there. A patient comes in anaphylaxis, potentially stridorous, they're looking crappy. You give them epi, you wait, nothing happens. Or you give it again, nothing happens. And someone says, hey, this is anaphylaxis. But was it really? Was it really the fact that we had anaphylaxis and we had refractory anaphylaxis to this, and we need to go and escalate to further and further care? We need the ICU team, we got to get ECMO, we got to do all these crazy things. Or should we just figure out if we did the right thing to begin with? So let's dive into this. And this episode is going to be Don't Ask Why, Give It in a Thigh. So we talked about this a little bit. After hearing that report, we have to get ourselves together and ask ourselves, did we really just do the right thing for this patient? And really doesn't really matter. That's another component. It's like, hey, I've been doing this all my life. It doesn't really matter. But when you start looking back at all these cases, the ones that escalated, are we preventing harm by doing the right thing early? And we're going to look at the math that proves that 50% of you are giving a placebo dose. 50% are giving a dose that really doesn't do anything, and the math's going to prove that you're underdosing it. And I'm also going to make another bold claim. Giving epi to the arm, it's just like giving saline to the arm. And injecting the arm is basically injecting saline and just scaring them, and their endogenous epinephrine is going to creep up. I'm going to prove this to you by reading the Bible of epi absorption that everyone quotes. You've seen the chart before, but you probably haven't dug deep into the study. So that's what we're going to do today. So the Simon and colleagues study that looked at this was done in 2021, and they looked at healthy male subjects. They had 0.3 milligrams of epinephrine administered. What they did was they used different sites and compared the plasma concentration, or the Cmax, that was measured. The component of this as well is that they had a critical control group that used saline. And realistically, getting stabbed with a needle stresses you out. Your body releases its own endogenous epinephrine, and they need to see if the drug was actually doing anything above the baseline. I call this the saline sham. Again, looking at the peak plasma concentrations, and what we saw in group 1 that had saline, their peak concentration, their Cmax, was 1458. And this is the group that says we just get stress epi from getting poked. That's their own endogenous epi. And then when you look at the group 2 that uses epinephrine 0.3 milligrams IM to the arm, they had a Cmax of 1821, the actual drug in the deltoid. And when we do the math, the authors say that an identical dose of epinephrine administered in the deltoid did not result in a significant elevation of plasma epinephrine concentrations in comparison with endogenous epinephrine after saline injection. This was in their discussion, and statistically, it was indistinguishable from stress of getting poked with saline. So realistically, the way I look at this, you would say, you aren't really treating the patient, you're just scaring them. And you're causing the patient to really just be stressed out, and we're not going to be treating them. But the patients that I'm worried about is the ones that can get sick and actually have something going on that really needs a big dose of epi. Well, if given saline to the arm or so so harmful, and it's basically like giving a placebo, giving saline every time you do it, what is the best way to do it? And what is that dose? We look at this study and we looked at the fact that the Cmax of giving IM epi to the thigh was 12,000 compared to 1,800. It was a tenfold difference, guys. It was a much bigger difference. And the way I like to look at it, it's like giving a squirt gun compared to giving a fire hose. And that's something that we really need to focus on. And a lot of the protocols say to give it in the thigh. A lot of people know to do that, but they don't always do it because realistically, what's the harm? I had the arm exposed. It was easy to do. So I gave the IM epi to the arm. But really, we noticed that we're not only giving saline, but we're actually not getting even the peak time that we're looking for when it comes to giving IM epi. So then the question becomes, why the thigh? Well, the physiology looks at you have greater blood flow in your thigh compared to giving to your arm. Your deltoid is going to be a smaller muscle bed, less vascular, poor perfusion and shock compared to your thigh is going to have it's a massive muscle. You're going to have big vessels going through there, highly vascularized, and it's going to maintain perfusion in the sense of the way I think of it is that you have this huge thigh and it's massive and it's highly vascularized muscle designed to run from tigers. It's designed to maintain perfusion for much longer than your deltoid is. There's a few people that say, well, Jimmy, back in my day, I used to give sub-Q. And, well, maybe I missed the muscle and I hit sub-Q. But Simon and colleagues, again, the Bible of IM epi absorption looked at that as well. And what they found was that the sub-Q arm had a Cmax of 2877. And that's actually higher than what was given IM to the arm. And we look at that and we say, well, we have that component. The IM absorption in the arm was so unpredictable, guys. It was so unpredictable that even given sub-Q had a higher Cmax than that. So that lets you know how unpredictable that was, that we know to switch over from sub-Q to IM, but even giving it to the arm is basically worse than giving sub-Q. So that's something to really pay attention to as well. But neither came close to that big dose that we was looking for of the 0.3 milligrams given to the thigh that had a resultant increase in Cmax to 12,000. And this is the chart, the table that is super famous that everyone talks about. And what I do is I usually get my team and say, hey, yellow and orange is going to be giving epi to the thigh. Again, EpiPen, the brand versus the generic. And I compare it to the green and the blue, which is going to be giving the sub-Q to the arm and then giving the IM to the arm. And then below that, that empty, the black one that's like right beside it, that's saline, guys. And I show them the numbers and they're like, oh. And one of the things I want you to also look at is that peak concentration, the time to Cmax. It's going to be much quicker. You're not even get close to that until you get really, if you start looking out maybe an hour to 2 hours out, you're still not even close, guys. So again, this lets us know that giving IM epi to the thigh is super important and it's something that we should all be focused on. So don't try to outsmart physiology. Don't ask why, give it in the thigh. So now that we've really talked about the location of that, let's transition to the dose. Because everyone's given 0.3, EpiPen is 0.3, and we've talked about this quite a bit, and it's been the standard for a while. But I would argue that looking at a few things, I would say that maybe given that 0.3 milligrams is basically like treating a child and the weight of a child. And in the US, particularly where I live and where I practice at, my patients are big. Again, they're much larger than what those patients were in the original studies. Looking at these patients that are 60 and 70 kilos, most of my patients are a lot bigger. And I want to prove that by looking at this paper that was done by Dreborg and colleagues in 2022. And it looked at all the international recommendations on epinephrine and anaphylaxis. And what we're trained on is anaphylaxis gives 0.3, but the therapeutic standard is the weight base of 0.01 mg per kg. And this paper really was a wake-up call for me. When you look at it and you dive deep into it, they have some phenomenal graphs. They have a lot of data, and they have a lot of math that looks at this. So if you look at the math, you look at these patients that 100 kilos. If you do the weight base, that is the standard. And I think what's a lot of the studies been looking at to kind of guide us to this dose finding comparison is that in this patient, the dose will be 1 milligram IM. Of course, that is going to be insane to think about. But when you compare it to the dose that we're given on a weight-based perspective, it's given 0.03 mg per kg. That's, again, you're given 30% of the required dose. for this particular patient. But you say, well, Jimmy, that's a little too big of a patient. That's not who I'm really seeing. Let's look at a smaller patient that's 60 kilos. Again, it's 132 pounds. They need 0.6 milligrams. And it's going to be compared to giving that 0.3 that we really give. That's only giving 0.05 mg per kg. Again, still 50% underdosing of that. And if we continue to look at this, the 0.3 milligrams is appropriate for a patient weighing 30 kilos. And last time I checked, a 30 kilo patient is a 9-year-old child. So we have to be really focused on what that looks like. And again, understanding that we may be doing something because it's easy, but doing something because it's easy doesn't always mean that the patient population that we see and what we're doing can be the best and absolute thing, particularly for the emergency department when we have the availability to use other components and other drugs. And I know some of you guys are using EpiPens only, but if you have the availability to use the 1 milligram per 1 ml and give a bigger dose, that's something you should consider. Another component that we look at is the fact that there's a lot of people who are actually giving sub-Q epinephrine believing that they're giving IM. And there is more variable mention of this with the skin to muscle distance that the authors realized. Many auto-injectors have a shorter needle, about 66 millimeters. In obese patients or even thick patients, the distance to muscle may be 22 millimeters or more, which your needle is way too short, and you're not giving IM epi. You're giving sub-Q epi. And remember what Simon and colleagues taught us about sub-Q epi. It's slow, it's weak, and it fails. So when looking at all this, I would propose that we have to take a step back. We have to take a step back and say, hey, should we look at this as a group? Should the societies look at this? And should we dive deeper and do more research, do more studies to actually analyze the difference in efficacy and making sure that we're actually giving the dose? Because again, we got this originally from the weight basing, and the weight basing we know works. We know for sure that works, and it may work better than the 0.3 for all of our patients. And we've seen this for many other drugs that we're maybe given too low of a dose to get the benefit that we want across all of the population. And there exists a more patient specific dose. And that's what I'm recommending. Again, us looking at this and saying, okay, let's change all of this. And I would propose that if a patient's greater than 50 kilos, give them 0.5 milligrams. And if we're going to be doing it, we need to make sure the delivery, we're actually giving IM using a needle that's going to be 1 to 1.5. And it's going to ensure deep muscle penetration. That's really going to be for our thicker patients to ensure that's happening. So you don't want to have to worry about whether we're doing it right or not. And then it comes to, well, what happens if we do all this and it escalates and we're just going to go to IV epi? And I hear that all the time. I want to close with this warning from Jang and colleagues that was done in 2020, because we're underdosing IM epi, again, the wrong site, the wrong dose. The patient doesn't get better. So the team says, hey, give me IV epi because the patient's refractory. The danger of that, when Jang reviewed 819 cases, when providers switched from IM to IV boluses, 99% of the time they were overdosing the patient. They slammed 1 milligram or the 0.5 milligrams IV. And what the result of that was more arrhythmias, more cardiac arrest, and other components. So realistically, you're trading a safe and effective therapy of 0.3 milligrams in the arm for a potentially lethal therapy of an IV overdose of giving that. So the sweet spot really lives in the middle of 0.5 milligrams IM in the thigh. That's going to be the key point that we want to focus on, making sure that we get to that sweet spot. So the Pharm So Hard anaphylaxis protocol, again, if your patient has anaphylaxis and they're getting epi, you want to give it in the thigh. And if your patient's over 50 kilos, you want to give that 0.5 milligrams. And the mantra that we should live by is don't ask why, give it in the thigh. So next time a patient, don't let them roll up their sleeve. Again, stop the line, expose the leg, and give 0.5 milligrams if you have access to it. I realize that this is going to be a big change, and I'm asking everyone to look at this, look at the data, and see what's going to be the best for all the patients versus just a few of them. Because again, that 0.5 compared to 0.3 does not lead to more adverse effects. The switching from IM to IV does lead to that. So if we're not adequately treating these patients and getting a higher range of patients that weigh more, we are potentially exposing them to additional things downstream and additional therapies and additional wait times, ICU admissions, all these things, we can just do the right thing at the beginning. So the one thing I know everyone can do, everyone can give IM epi to the thigh. That's the key takeaway. Consider, again, looking at the dose and really make sure you have the right needle and focusing on making sure we let everyone know, hey, we may not have done the right dose. We may not have done this. The patient hasn't got the adequate. We haven't failed therapy because we haven't done therapy right the first time. So let's focus on that. Let's make sure that we're being the kinetic expert in the room and making sure our patients are getting the best therapy. All right, guys, I think I have drove this home. Give the drugs the way we need to. Think about this and realize that we could be giving it wrong in quite a bit of the patients. But before we close out, few announcement, guys. Go ahead and head over to empharmacist.org and check out our new journal. Again, the Journal of Acute Care Pharmacotherapy. We just posted our first volume. We're super excited to be part of that with Brian Gilbert, Chris Edwards. Those guys really provided a ton of leadership when it came to making the first, again, open access, again, peer review. We have a huge editorial team, and this is something that's going to be great for all authors, whether you're critical care, infectious disease, pre-hospital, you're a physician, you're a nurse, you're a pharmacist. The Journal of Acute Care Pharmacotherapy basically looks at anything with a drug in the acute care space and makes sure that it's open access. So super excited for that. For those who's looking for networking, looking for education, continuing education credits, definitely come hang out with us in Orlando, Florida for the 5th annual Empower RX conference. Almost everything that I've been able to do has been built off the initial point of the podcast that led to the conference. The conference led to the Society of Emergency Medicine Pharmacists. And I'm just beyond just excited and overjoyed with the reaction that we've gotten from the community. This is going to be a really big one for us, the biggest one yet, because we have a few things that we're doing. We're doing some pre-conference workshops, hands-on things, pumps, pressors, medication administration, working with our nursing team to help us with that. Again, really pushing us to the next level. And what we envision the conference being is a place you come to gain skills, not just sit back and listen, but you come there, you're going to be, very comfortable. You're going to have one day you come in, you probably have some scrubs on, and we're going to get our hands dirty. We're going to be doing a lot more of these things. We're going to have some simulations. So we're really excited, and we're taking the information that the audience is giving us and told us they want, and we're just doing it. Because again, everything is going to be for us and by us. We're nonprofit. So again, for those who are concerned about that component, again, we have everything set. We have ways to donate for residents and students to come. So we're really excited about all these recommendations that's come in our surveys, and when people just send in text messages and calling, said, hey, I want to make this happen for our conference. And that's the cool part about the Empower X conference, is that it's literally your conference. So when you come, you can be yourself, you can network, you can learn, get you 15 hours of continuing education credit. Again, if you can't physically be with us in person, we have the virtual live session. We're going to be streaming it for you. We went out our way to make sure we've been doing that for every year we've been part of it, because we want everyone, whether you're going to be in Australia, Saudi Arabia, Canada, no matter where you're at, we want to make sure that you're part of the experience. And we're super excited. Every year we've done this, we've been represented by over 15 countries. That's phenomenal. And the cool part is that every year as well, we have in person, someone's come a flight that's over 10 hours to hang out with us. So I'm really excited. Again, Gary Ward, all of you guys that's come from all over. Again, Anthony, thank all of you guys for over the last few years coming and experiencing things with us, and the relationships has grown from that. So we're very excited for this conference, and it's going to be the best one yet. We have a surprise that I promise you, if you don't come, you're going to be so sad you missed it. You're going to have a ton of FOMO. So I'm going to go ahead and close out there, guys. I'm super excited about everything that's going on. Again, getting back to podcasting, I'm doing something like every day now. Shout out to my institution. Again, we're recruiting for our first we already committed the first year for our PGY2 program. So I'm excited to be at RPD now and really going through the accreditation and all these things. So a lot going on. That's why I haven't recorded as much in the past, but we're excited for this new year, new opportunities, and the best yet. So guys, you don't have to be a pharmacist. You don't work at the ED, but everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.